I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor. Welcome to another episode of Women's Health Unplugged. I'm Dr. Jordan Robertson, and I see the absolute irony in me recording this podcast as I sip a beautiful cup of coffee and eat a couple of Reese's peanut butter cups. It's literally my absolute favorite. I don't know if even do we call it candy? Is that candy or is that chocolate? Anyways, that flavor combination of the chocolate and the peanut butter, hands down, is my favorite. I do accept bribes. And so if you ever needed to bribe me for anything, a solid Reese's peanut butter cup, I'm totally in. Anyways, the irony here is that I wanted to talk today about the impact of food and nutrition on joint pain. And we're going to talk a little bit about what the research shows right now and where I think it's going. And I don't do that often, where I talk about, or make prospective remarks about what may happen in the future. We can't sell potential, right? Meaning that we can't sell an idea based on what we think might happen or what might potentially happen in the future. But I do want you to understand where the research on nutrition and joint pain or arthritis is going. Partly to help you be able to see, the myth from fact as we move forward. I do think there's going to be an explosion of conversation about joint pain in the integrative medicine space and in the online space, specifically because we know that women around the age of menopause and even in perimenopause, so we're going to say 40 and up, are at a higher risk of osteoarthritis and joint pain than males. And partly it's because of that loss of estrogen. Estrogen is part of our kind of anti-pain systems and really does help temper joint pain. And so even though we may not see massive structural changes that change after menopause, we also see some structural changes that happen after menopause, but they don't really line up with the amount of joint pain that we see. And that's tough. It's tough when we scan a joint and it looks fine, but patients have pain. It's tough when we scan a joint and it looks terrible and the patient has no idea. Arthritis is one of those pieces where the connection between what we see on a radiograph or on an x-ray maybe isn't what you experience per se. But back to my original point, I think we're going to see a lot of discussion about joint pain over the next 5 years as we continue to try and monopolize, and there's that commodification of menopause happening in the online health and wellness space. I think you're going to have lots of people claiming that they have the latest and greatest and newest and bestest way of supporting and treating joint pain through nutrition. When just like all conversations with nutrition, we can really do people a disservice if we make them feel like their pain is their fault because they're eating a particular way, or if we make them feel like if they just tried harder with their nutrition that they could solve their own problems. I really don't want you to feel like that coming out of this conversation today. That isn't what the research suggests, really. But I'm going to show you where it sits right now so that you can make some educated decisions about your joint pain and your nutrition, and then also be able to see, again, fact from fiction. I don't want you buying any crappy books on how to solve your joint pain through changing your food. And the two things I want to focus on in this conversation, like the kind of learning moments, one of them is we're going to talk about a concept in science that's called biological plausibility. I promise we'll make this that sound more fun than it sounds. But the other thing I want to talk about is meal replacement as a behavioral strategy for supporting nutrition, because as you'll see, the dominant conversation in the research around joint pain and nutrition is around using meal replacements. And I feel like the word meal replacement is a literal swear word in the health and wellness space, when I don't think that that should be the case. And I think we have lots to learn about studies that use meal replacement on how to support people moving towards a nutrition plan or pattern that actually supports their health journey better. And I'm going to say, more easily than maybe some of the ways that we approach it. I think if you've ever, tried to make changes to your nutrition and landed on some, recipe blog page where the person teaches you how to like milk the goat and make your own cheese and grow your own avocado as part of the recipe, you'll very much appreciate the conversation about meal replacement, because it does bring that nutrition conversation down to this level of practicality that I feel like most of my busy, high-performing women who don't always love to be in the kitchen can still participate in a nutrition conversation if we use those behavioral tactic type strategies like meal replacement, or what I think meal replacement actually really represents in the research. So let's start by dispelling some of the myths on nutrition and arthritis or joint pain. And this is my term here that I wanted to share with you, this biological plausibility. And really what this term in research and science is geared towards is it's to help us draw a line between cause and effect of things that we maybe couldn't otherwise run a well-controlled or well-developed research study. So, at first glance, you may think, well, why wouldn't you just run a good research study, right? If you wanted to research something, why can't we just research it? But the reality is that there are a lot of things that happen in the environment or things that we observe as part of our human culture that it's not actually ethical to run a research trial on. So I always use the example of smoking, but we can't randomize people to being a smoker, right? We can't say, okay, all of you, 500 healthy people, 250 of you, you must start smoking now. And you know what? 10 years from now, we're going to find out which of you got lung cancer. We can't run a trial like that. And yet we would really love to be able to draw a line between smoking and cancer. So how, right? How do we do that? And partly it's that we make observations about what happens to that population of smokers. But also we wanted to know and understand that it was biologically possible that smoking contributed to cancer risk. And I'm not going to pretend to be an expert on what actually happens inside your lungs when you smoke, but that idea of okay, I'm inhaling this thing and this thing changes cells, and changing cells causes cancer. And as it turns out, our lung cancer, or our smokers do have more lung cancer. So biologically, it makes sense that the smoking was the cause. We see it happening more often in this group. And so we're a little happy with drawing this line between those two things and saying this is probably causation, even though we could never run a formal randomized control trial, meaning that we split everybody up and we subjected some people to the thing and some people not, and to see what happens. We can't do that. And where we make mistakes often in research in integrative medicine is that we use that biological plausibility to explain lots of things when otherwise we could have just run a really good research study. And so one of those examples is the conversation about lectins and joint pain. So lectins, and again, I've spent only as much time on this as I needed to just realize how ridiculous these claims were. But lectins are a protein-like molecule that's found in a lot of foods, and a lot of foods that we would otherwise consider to be quite healthy. Legumes, nuts and seeds, some vegetables. They're actually in lots of foods, but they're particularly high in some of those foods that I just mentioned. Now, the gurus of the lectins cause all disease movement claim that your immune system has the ability to recognize these lectins, and then they start to draw their line between biological plausibility And they say, well, if your immune system can recognize these things found in chickpeas, and your immune system is also activated in arthritis, well, these lectins are probably the cause of all pain and suffering in the human race. And I know I'm being a bit cheeky, but that line can't be drawn that quickly. It's also not unethical to randomize people to a diet full of chickpeas. And yet, we've developed this entire notion around what these food-based molecules are doing inside the bodies of people, including being a contributor to joint pain, when we very easily could test this out, and yet no one has bothered to. Actually, even the person who's written the book, which shall remain nameless for now, on how lectins are the root of all evil in the human race, who actually happens to be a doctor, which is frustrating because as a person from the public, if you saw this doctor with these credentials that they have, tooting this horn saying that these foods were all bad and you had joint pain and you were desperately looking for a solution, you might start to believe him. Except they haven't published a single paper on it. It's all cells drawn on paper where we go, yeah, the immune system recognizes these proteins. And the immune system does lots of things and causes pain and inflammation in patients with joint pain. And so we're pretty sure that if we take those foods away, that person is going to get better. And that's just not the case. And actually, we see that conversation when we talk about gluten and joint pain, or dairy and joint pain, or nightshades and joint pain, or lectins and joint pain. There is yet to be a single food that we've found that if we take it away from a human, that their joint pain gets better. And now some of those things that I've mentioned are because we literally have no research on it. And so what ends up happening, especially in the online space, is you will hear Judy, who did take gluten out of her diet, and now her joint pain is miraculously gone. Now she's got an entire blog on the topic, and that feels like research. Except we don't have any studies that show that, and we don't have any research that shows it. And I was saying this to my group of clinicians. I run a large database for integrative medicine clinicians to support them in their pursuit of evidence-based practice with their patients. I said, you know what? We don't have to come up with a crazy new idea for how to support patients with joint pain. We actually have a lot of research on what to do. So why are we looking for this, unique, special, novel idea when the ideas we have are actually pretty good? I'm just not sure that we're sharing them with patients. I'm not sure you've ever gone to the doctor to refill your pain medicine prescription and they've ever mentioned your nutrition and the impact that might have on your joint pain. So let's not come up with the most novel new idea. Let's actually just talk about what does work. And I think patients would really benefit from that. And here you are, right? Looking for solutions for your joint pain that you can control. And maybe we can support you by having good conversations about your nutrition. So I wanted you to be armed with that sort of ammo in your mind that just because we can see things that might happen according to a drawing of a cell, or just because your immune system can recognize something doesn't mean that it's toxic or doesn't mean that it's bad. Our immune system is designed to notice things. And so, we have zero research that taking chickpeas away does anything. And so we're probably causing harm by leading patients down this path of belief that they should take food out of their diet because of what they're eating is causing their joint pain. That's just not the case. So sorry for a total rant there, but you really do need to be equipped with that because you will come across that information. And I want you to have those spidey senses going off, going like, well, has this ever been studied in humans? Because this looks like a drawing of a cell. So where does the research live when it comes to arthritis? It's interesting because when we talk to patients, they will often cite their weight as being the biggest contributor to their joint pain, specifically their joint pain in their load-bearing joints like their knees and their hips. It's not very often that patients will say, well, if I just lost 5 pounds, the pain in my thumb would be better. We make that connection with our load-bearing joints. But interestingly, our actual weight on the scale doesn't have like 100% of the pull on why we have joint pain, right? If I gave you, and I use this example with patients all the time, I say, if I gave you a 5-pound bag of sugar and you had to carry it around all day, like your joint pain's not worse necessarily. So losing 5 pounds doesn't automatically mean that your joint pain is better. It's not about the weight. And we thought that for a long time. We thought that like the shearing force on your joints was an issue. And it's not the sole issue. There actually was one particular study that went through and sort of what we call it like stratified patients based off of their waist circumference, but also based off of like inflammatory markers, and to look and see whether or not we think the greatest contributor to someone's arthritis pain is their weight, or is it their inflammation associated with carrying extra weight. And as far as we could tell, they were really kind of equal contributors to the entire system. And so both having that elevated BMI and having elevated waist circumference, which waist circumference is a bit more of a marker of like inflammation associated with weight, right? That abdominal weight carrying is more of an inflammatory. I'm really making this quite basic, but carrying adiposity there or having fat gain there is different than all over weight carrying as far as inflammation goes. And both were really contributors. So yes, there's this shearing force of being heavier on your joints, but also there is this inflammatory impact of sitting at a higher BMI that may be contributing to your joint pain just as much as the actual physical force that is pushing on that joint. But it's led for most of the research on joint pain to be on weight loss, for better or for worse, right? And how I feel about using weight loss as a sole target in patient plans. You know that I'm very mindful and sensitive of disordered eating and the impact that discussing weight loss at all costs is with patients. I know what that looks like when we talk about that, like with real humans. But I do want to share what the research actually says, because I do think there's some insightful things that we can learn from it. But it led that idea of like, okay, is it mechanical force or is it inflammation? That really led us down this path of like searching for the impact that weight management has on joint pain. And so, as I said at the beginning, the majority of the studies that have looked at joint pain and nutrition have looked at meal replacements. I also mentioned that meal replacement might be a swear word in my industry, but I do think there's some pause for reflect here and thinking about why this shows up as being a successful intervention, and how do we practically apply this in a way that actually helps our patients and meets them where their needs are. Really, meal replacement is a behavioral intervention, right? So if we think about some of the barriers that we have to making nutritional choices that are on a path towards weight loss, right? So when I say that, I mean, looking at that caloric adequacy or caloric deficit over the course of 24 hours. How do we help people get there, and what are the barriers to getting there in the everyday average person? And a lot of the barriers that come down to patients being able to execute on a weight management plan have to do with their life, right? It's not their knowledge, right? It's not that they don't know what to eat, although sometimes we can certainly give some education around what to eat. But if we have people point like, well, is the apple pie better? Is the chicken better? People know, right? It's not knowledge. It usually comes down to other life circumstances that get in the way of being able to do this very hard task of weight loss every single day for 100 days. And so when we look at meal replacement, what does that do? It takes away choice, relatively inexpensive. It takes away decision making. It takes away confusion. It's portable. It's fast. Right? And so when we talk to patients about what their barriers are, it's cost. It's trying to change the culture in their own family, which sometimes meal replacement will solve, because now it's, they're not just like picking at half of the meal that their partner made. They're doing something completely different. It's the practicality, it's the portability, it's being able to execute it on work days and non-work days, and when they're traveling, and all these pieces. The concept around meal replacement, and when I say meal replacement, I'm thinking in my head like a Boost shake or Ensure that you open like a pop, right? Where you snap the top and then drink it. that's solving a lot of those barriers that we have. And they generally, if we're talking about commercial grade meal replacements, are fortified to be to prevent nutritional deficiency. When from a clinical perspective, when we look at people cutting out calories in food on their own, we don't always do it in a way that means that you get the right amount of vitamin A or the right amount of zinc, because you may be cutting out foods for the sake of calories and not eating anything fortified. So the majority of the research has been in that space of meal replacement, for better or for worse. Is Boost great? I don't know, right? I'm sure that we can pick it apart. There's definitely some ingredients on that label that I can't pronounce. But there's ingredients in bananas I can't pronounce either. It's the concept. And so could you replace it or replicate it in some way in your life that meant you weren't buying, shelf-stable, prepackaged chocolate shakes? Probably, right? I want you to think about the concept and what does that mean? Is it about repetition and ease and cost? Those are the things that really we need to take into consideration when we're talking about how to support patients in the long haul with weight management. But interestingly, when patients were prescribed the weight loss through meal replacement, we actually generally see improvement in pain. So pain scores for the knee, and we look at, most of the research is on knees. So let's just, start with that. I'm not avoiding talking about your hands or the arthritis in your thumbs. It's just that we don't have any research on it. It's actually mostly on your knees. And so that vast majority of research is looking at using meal replacement for knee pain. And the way we score arthritis is, the things that you're very aware of in your joint pain, like morning stiffness and how much do you have to limit your activity during the day, and what your pain actually is, your pain score. And patients who use meal replacement as part of a weight loss protocol actually have a reduction in pain and an improvement in their stiffness, their morning stiffness, and an improvement in their functionality. And I think that's a really important point to make, right? That it was like, interestingly, they lost weight, which is great. They did it in a way that we would never normally prescribe, right? Is that the best food quality to have a shake? Maybe not. And yet they still seem to achieve the outcome that we were kind of looking for. Now, the research on nutrition and arthritis and weight loss has tried to slice it in many different ways, right? How long should it take? What if we do it rapidly? What if we do it for a long time? Can we maintain weight loss with these patients over time? But the overarching theme is that when patients have that weight loss, they do see improvement in their joints. And so if we hold that in our hand as our most important treatment outcome, it didn't really seem to matter, what the scenario was or what their plan was, is that it was as long as they lost somewhere in that neighborhood of about 5 to 10, some studies were hovering in the middle there, maybe at 7% of their starting weight, their knee pain significantly went down. Their need for analgesics went down, meaning painkillers. And then there was even a couple of studies that looked at the impact of whether or not those patients progressed to knee replacement. And we do think that that's happening a little bit less often. And when combined with exercise, then we're generally seeing like even better outcomes in these patients. And so this is one of those times where, I don't think we need to lose weight at all costs very often. And I'm not saying that this is one of those times, but what I am saying is that rather than exploring the, should I take this food out or this food out or this food out for my joint pain, we really need to take much more of a global look at your nutrition and compare that to what would be, what your actual body's needs are from a fueling perspective, and make sure that those are meeting the goal that you have of having lower inflammation and less joint pain. So the question which should naturally come up is like, well, what about food quality? Right? That's nice, Jordan, that if we change the quantity that we see a change, but what about food quality? And so the research is shifting in the conversation about arthritis and food. And it's moving much more towards looking at the impact that food choices have on arthritis. So not just food quantity, but also the quality. And I said at the beginning of the podcast, I don't like to make projections about what I think is going to happen, but we're seeing this shift in research like in other areas where all of a sudden the food quality conversation is kind of coming in sideways at the weight loss conversation and saying, well, yeah, like we want patients to not have excess inflammation due to adiposity. So weight loss is important, but maybe it actually matters what we feed them or what they choose. And so we're starting to see in most of the research on looking at saturated fat, looking at the Mediterranean diet, were all published in the last couple of years, some of them even in 2022, where we're seeing the addition of not just a weight management program, but also looking at what we feed the patients. And so one study in particular, which was done in 2022, didn't use meal replacements. It's really like honestly one of the only ones that doesn't use meal replacement, but they fed patients a calorie restricted diet that was focused on the Mediterranean diet principles, which meant they had to get a lot of fiber, whole grains. They had minimal red meat. They were allowed to eat very little red meat over the course of the month. They had to have olive oil every day, and they had to drink a lot of water. And in this particular study, they actually gave them fish oil, which was a little bit of a blunder, in my opinion, just from a study perspective. I don't like to give a supplement in a diet study because it makes you question what did what, even though the fish oil research on arthritis is pretty poor. So I'm sure that the fish oil didn't add a whole lot to the improvement. But despite equal weight loss, they actually found that the Mediterranean diet outperformed a low-fat diet or just a diet that caused weight loss with respect to pain. So both groups got better than the group that did nothing with their nutrition. So there was a group that just hung out and ate the way they always ate, and their joint pain actually worsened over the months of the study. But both groups that were supported with their diet. So one group was given this Mediterranean diet and the other group was given a low-calorie diet for weight loss. They both lost the same amount of weight, but the Mediterranean diet had better pain scores, meaning that their pain had gone down more. Their physical function was better. Their stiffness was better. Their stiffness while standing was better. It was really like every single outcome that we looked at was better if the patients ate the Mediterranean diet. Now, what does this do against like the, maybe 50 studies we have on meal replacements for arthritis, right? It feels like a drop in the bucket compared to most of the other conversations we get to have about joint pain, except that we're seeing this general trend and shift in the research suggesting that we probably need to have two conversations with patients about their nutrition. We need to talk about their total fueling and the impact that over or under fueling might be having on their health condition. And with respect to osteoarthritis, it's really over fueling that's the bigger concern. If you're listening to this and you have, your BMR and BMI is in the range that we kind of would consider to be that healthy range, not overweight or obese, and you still have joint pain, that's still possible, right? And it may not mean that you need to lose weight necessarily. But when we look at the impact of a larger body and obesity on joint pain, we do know that this is one of the things that's going to predict or increase your risk of joint pain. And if we can support you in that, then maybe we can improve your joint pain over time. And so that's really that first part of that conversation that we should be having is around like total fueling and the impact that overfueling or increase in body weight may have on joint pain. And I'll tell you, a lot of the studies were done on women, not all of them, but at the very least, they were almost 50-50 if they were a combined sex study looking at knee osteoarthritis. Like I said, it's more common in women. These studies were done in women. So even though at the beginning I said that hormones play such a significant impact, the mechanism by how diet is supporting patients is partly through helping them maintain an ideal body weight. But the second part of that conversation needs to look at diet quality and the studies that are starting to emerge around saturated fat and inflammation in the diet versus the more anti-inflammatory Mediterranean style of eating, the high flavonoid, which is like high fruits and vegetable, high olive oil, low saturated fat diet is going to start to prevail, in my opinion, in what we see on that conversation around arthritis. And so even though right now we're probably talking 3 studies up against 50 on meal replacements, we're starting to see that conversation. And so if that feels like a more appropriate place for you to start, or if that part of the conversation has never really occurred to you, like, well, what am I eating as a totality versus thinking specifically about foods? If you've pointed your finger at a specific food in your diet that's causing arthritis, we're missing like forest for the trees. I want you to think about your entire dietary pattern over the course of a week and a month. Leaning towards that Mediterranean style of eating is where we're going to see the biggest impact on joint pain and probably have a great impact on weight management as well. So I felt like that was an important episode to share, partly because so many of you, if you don't have joint pain now, I'm not going to say we're all destined. I also feel a bit of a personal connection with this one. I have pretty significant arthritis in one knee. That I want this information to feel readily available to you. And I also want you to be able to read sort of fact from fiction as the information around joint pain in women starts to really hit center stage. If something is being marketed as new and novel, like, remember that it's ignoring the last 50 years of research we have on how to support patients with nutrition. And that was I listened to a great podcast about someone, poo-pooing the lectin conversation, kind of said like, that saying that food is the root of all evil in the human race is ignoring 99.9% of all research on nutrition. Right? And so you're probably going to see and hear other big claims that are made that this food is magic and this food is terrible. And I want you to have your wits about you to be able to say, like, did they study that in people? Or did they just do a drawing of a cell and showed me here how this is making an impact? Because we're smarter than that. We want to see good research done in real life humans before we start to actually try and shift your life to use a particular intervention. And if you're really struggling with your arthritis, I mean, there's actually quite great research on using supplements and nutraceuticals to support arthritis, and can be as effective as using NSAIDs. I would suggest that you reach out to your naturopathic doctor, and if you don't have one, I know where you can find one, and we'll connect soon. I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team.